All right, welcome everybody. I believe we're kicking off the webinar at this point in time. Thank you for joining us today. The topic of our conversation today is really around analytics for value-based care, particularly from the perspective of provider organizations. However, we're going to take a slightly different perspective on what analytics actually means in the value-based care world. Typically, when people think about analytics and value-based care, it's often about the insights that are associated specifically with population health management, and it's often also with the lens of retrospective reporting or dashboards and so forth. And in this case, we're referring to tools that really tell us what happened in the past. But to be successful in value-based care for 2026 and beyond, we really believe that this depends on something a little bit different. And that difference is intelligence that happens in real time that is then connected across what we refer to at Innovisor as the value-based care life cycle. What that means is essentially having connected financial precision on contracted outcomes for value-based care and not just from the lens of population health operations. So what we're discussing today is really a shift from a retrospective discipline to a predictive operating system. So the good news, I think, for everybody here is that value-based care is really not new. Everyone here probably knows about attribution, benchmarks, quality measures, risk adjustment, and so forth. But what we often see is missing throughout organizations is the tie of those operational metrics and KPIs to the contracted KPIs that really dictate the financial performance of value-based care. And by bringing those things together in one connected workflow, that's really what we're aiming to move the needle on. So today we'll talk about how organizations can really proactively design their contracts, continuously manage that performance, and then reconcile the outcomes with transparency, all on one unified system. So if we can begin and move to the next slide then. All right, so speaking to you today is myself, Jim Hong. I'm the SVP of Analytics at Innovisor. I've spent about 2 decades in the healthcare system, mostly in the intersection of risk-bearing entities with analytics, data science, and AI. And joining me is Puneet. Puneet, would you like to introduce yourself?
Yeah, hi, this is Puneet. I'm an actuary from background, so I've worked in the industry for about 20 years, worked with Milliman Consulting, Deloitte, Cigna, and then I was a chief actuary for a health plan in upstate New York, CDPHP, for almost 10 years before I started the journey of Humvee. We primarily focused on value-based contracts, both for payers and providers, and come this January, now be a part of Innovacity team.
All right, great. So Puneet and I will be speaking to you today. And before we really get into the meat of our conversation, we'd like to start with a poll question, which is to assess from the group here, what do you feel like is the biggest VBC analytics challenge that you're facing today? Is it fragmented data from multiple systems? Is it the potential 3 to 6 month performance lag due to things like claims IBNR and so forth? Is it the need for manual reconciliation of your performance against what payers tend to report out? Is it that you can't predict future contract outcomes quite as easily? Or is it something as simple as just not being able to identify high risk members in the population that you're managing? So we'll wait a minute for responses to roll in, and then we'll take a look at what most people feel. All right. So looking at the results a little bit here, we do see some fragmentation of the responses to begin with, but the predominant winner here seems to be fragmented data from multiple systems. Obviously, that can be a number of different things. We will share our perspective on what fragmentation means today. We also see that coming in number two is the inability or the difficulty with predicting future contract outcomes. And so really these two aspects are the heart of our conversation today. So let's move into first maybe framing what the problem really is that we see, which is that based on research that we've seen, we'll move to the next slide, please. Right. So we found that, healthcare providers lose up to, or maybe even more than 9% of the contract value, specifically just due to contract management and analytics. And so, when we think about some of the reasons why that might be, we know that performance data is often delayed by 3 months, 4 months, or even 6 months behind, depending on how frequently the data is coming in and what your technology stack looks like. We see that it's not necessarily a people or effort problem. Every provider organization is spending oodles of time and potentially oodles of money on ensuring that data is rolling in at the right speed, that payer data is being processed correctly, that attribution is being reflected appropriately, that risk scores are being normalized appropriately, and any data discrepancies are being managed. So that work is essential, but it costs time, it costs money, and we believe that the real challenge here isn't so much that there's not enough focus on this, but really it's a technology and operating model problem that organizations are facing, and specifically that attributes to what I addressed at the beginning, which is that disconnectedness, the fragmentation of what is more a contract and financial analysis versus what is more a population health management aspect. So if we go one slide forward in terms of what we have observed in the market, yeah, in terms of what we have observed in the market, we see that there are a couple of manifestations of why this might be the case. So let's move ahead one slide. Right. Based on what we've seen in the market, about 70% of payers say that providers, are still managing the contracting expertise and understanding these value-based contracts that are put in front of them. There is certainly a risk aversion to potentially taking downside risk, and obviously with downside risk is usually higher potential for upside rewards. So that is still largely not as appetizing as we found it could be. And then the last point, which I think is the most salient point, which is that there is operational friction between really understanding the contract and what it takes to succeed financially versus just conducting population health management. And so these three, data points are really manifestations of, why providers might still be finding difficulty in being successful in value-based care. And I think at the root of this, if we move to the next slide, there are a number of different issues that we just want to highlight here. Right. So why is it that this has been so difficult? And we believe that it really comes down to four different distinct reasons. The first one is just simply that contracts are convoluted, they are complex, they're delivered via, lengthy documents in PDFs, and the rules differ from payer to payer. So there's often a misalignment between understanding that contract fully and what it takes to be successful there, and the terms that are given. The second is having the right tools and the power and information to be able to do modeling and negotiation successfully with payers. So lacking, we know within the industry that actuaries like Puneet have existed predominantly on the payer side. We are seeing more and more actuaries on the provider organization side where they're really empowered to be able to negotiate and model out these different scenarios. So that's number two. Number three is simply sort of a little bit more traditionally what we regard as analytics, but it's from the lens of how are we tracking the performance against the contract itself, not necessarily simply with regards to your common population health metrics like PMPM and total cost of care and the various utilization KPIs, but specifically how does all that translate into the performance against the contract? Right? And then that leads into the fourth point here, which is really there's needs to be a greater link between understanding what it takes to be successful and then the operational execution of that and potentially putting that information in the hands of the operators so they know exactly where to focus. So Panine, I'm going to call on you here, and of these four, are there any that you feel strongly stands out in your experience managing and helping provider organizations understand what it takes to be successful in value-based care?
Yeah, sure. I'll kind of give you example of my experience. I've worked with payers for more than 14 years, and then in Humby as a consultant, and prior to Humby, Deloitte or Milliman as a consultant. What I've seen with providers with all fee-for-service contracts coming from CMS, either it's Reach, VRDC, Teams, Reach, MSSP models. CMS shares CCLF files data. It's pretty transparent how all the data sharing is happening. There'll be some nuances so for substance abuse or members pulling out, but then all the providers get quarterly reports. So they know how they are performing on a quarterly basis. Of course, there are trends and risk score normalization that are adjusted while you are in the contract year. So there's always um, um, so uh, so I feel like there's more transparency from CMS side. I've seen a struggle when I talk to providers on the payer side. And one of the point that Jim was making, there is a reluctancy in terms of taking the downside risk, and that could be in terms of data transparency that payers are sharing with providers. I think that is the next phase of value-based contract that we will see more data transparency that we need to see from payers to the provider groups when they are taking downside risk. Providers should be able to calculate how we are able to calculate in CMS model exactly what their benchmarks are using last 3 years of data, and then how they're performing on a monthly basis, and not just rely on the reports that payers are sharing. And because of that, I've seen more downside risk moving in when the contract negotiation comes in to upside only or fee for service plus quality bonus opportunities. So I see that struggle both from the PCP based contracts or specialty based contracts where they feel they don't have enough information to take a downside risk. And that really leads to that 8.6% that Jim had, not having full transparency in terms of how their contract is performing on a monthly or a quarterly basis.
Yeah, thanks for that insight, Pani. And I think that's really telling. So, and what you're kind of referring to is more than just the fragmentation of data that happens within an organization, within a provider organization, but even the fragmentation of data that exists between payers having really all of the data and providers only having some of it, with which to make decisions about where they should be taking risks. So, and I think that again lends to the point of having a more connected system that has comprehensive data that is shared between payers and providers on one ecosystem and on one platform would lead to more transparency and understanding the risk that providers actually taking on. So great insight there. So team, let's move ahead one slide and talk about more broadly the shift that we believe needs to happen. So, at a very high level, these are sort of the four changes that we believe analytics needs to adopt as we move into 2026. And we've heard the whole sort of retrospective and predictive and prescriptive divide quite a bit. Again, that's typically within population health management, but when we think about value-based care more holistically, understanding the predictive possibilities of the contract that you're entering into is just as important and maybe even more important than understanding, the population that you've been given and how to be successful there. So that first shift from retrospective to predictive, it extends, before the population health management initiatives take over. The other is, I think the other shift from a lot of the work right now in terms of understanding the financial success is still done fairly manually through Excel and so forth. And while Excel is a very flexible tool, with the dynamics that happen in data in real time, you really want to get ahead of that and leverage the technology that we have today to make potentially better projections into the future and have more real-time information. So both of those things lead into the third point, which is really we believe that analytics should be much more proactive rather than reactive. And so that requires a different frame of mind and different data and technology to be connected together in order to enable that proactivity. And that ultimately rests on the fourth point here, which is that siloed information, whether it's within the provider organization or whether it's between payers and providers, really needs to become more integrated and connected between the two. So, all right, so let's talk about maybe a little bit what that looks like as we move into the future. Right. So this is our view on, again, that VBC contract lifecycle. And if you spend any time with Innovacer, we love sort of breaking the value-based care experience into really kind of three different segments. The first segment is on the left, where it's all about designing that right contract so that you're setting yourself up for success. The middle tier is then all the analysis that happens to be able to be successful in that contract and really understanding where you are financially, where you could be financially, and understanding that at a very detailed level. So that middle bucket is, traditionally where industry professionals think about when they think about analytics is really that middle layer. But this is a broader view that ultimately ends on the right there with the reconciliation. So that piece, that last piece is obviously probably the most critical aspect here, which is, you can design a contract appropriately, you can analyze to empower your population health and operations, but ultimately you want to make sure that there's enough precision in all the data that you're working with and all the insights that you're working with, that you're ultimately rewarded for all of the good work that goes into it. And so by essentially zooming out from that middle tier of just pure analysis into understanding the analytical possibilities of design and reconciliation, that presents a much broader picture that I think creates a better potential for success in value-based care. Puneet, as an actuary, I'm curious to get your take on where do you feel like historically actuaries have played within this life cycle?
I think you're right in terms of actuaries live in Excel, and now with Innovator, we are moving that into a platform where we can analyze or reconcile results on a continuous basis. Um, when you ask where we spend most time, I think reconciliation is where I would love to spend more time. Either it's IBNRs, either it's trends. I don't want clients getting excited looking at February data. IBNR is huge. It's 28 days in the month. Seasonality is not there. So once we start fixing those things and see how you're performing against your target or the benchmark, whatever it was, a claims-based or MLR-based target, whatever it was set up, how you're performing in those cycles. And of course, we'll work with you on a monthly, quarterly basis to see how we are tracking, either it's inpatient costs or professional costs, what is driving the cost up or a downward trend, and what's working, what's not working. Is it like the risk score normalization are impacting you positively or negatively? That's where I actually spend most time. And then once we really understand all the value-based contracts that you're in, design becomes really the critical point at time of contract negotiation. That's where all the historical knowledge comes in, what we have seen historically in last 10, 15 years of VBC world, what contract you should sign. And every contract is different. If you're a PCP based, then you can start with the capitation or a MLR based contract. But if you're a specialist, and depending on how mature your specialist contracts are, you've been out in the market for a year or two, you've been running specialty VBC contracts for a couple of years. It all depends which cycle you are in, and that's where the design part comes in. Yeah, so it's kind of continuous improvement cycle. And generally, the contracts are signed 3 years, and we want to make sure when you sign these contracts, you have a pretty good idea of what next 3 years looks like in your projections. And then when the next cycle of renewal comes in, we are kind of working with you in terms of how to redesign or how to renegotiate. Either it's a 3 year cycle or a 1 year cycle, and that's a negotiation. Either like with CMS, you don't have negotiation; you just have to follow their rules. But they are very good in getting the feedback, listening to us, and with payers, there's a lot of negotiation that goes on an annual basis.
Yeah, so thanks for that insight, Pani. And what I'm going to distill from what you said essentially is that actuaries have been or should be involved in all three phases of this life cycle that we depicted here. I think where you started was on the right with reconciliation, and certainly that is very important to make sure that the appropriate financial outcomes are being dispersed appropriately. But really, it's throughout the life cycle where there needs to be actual precision in understanding, what your opportunities are in that middle bucket, what you should be improving on, where you should you be focusing your operations and performance improvement, and also probably more importantly in the design phase where that's that's the place that you're really kind of setting up yourself for success in terms of the risk terms that you're taking on, as well as the population that you're taking um, risk on as well. And so, I think when we think about this lens from the payer perspective, just to imagine that for a little bit, it's also a life cycle, but it's a little bit of the flip side of the coin for them. Now, when I think about that, where value-based care really starts on the payer side is with actuaries designing a contract, or at least identifying, where there are populations that they want to engage providers with to take on risk. And so I think all of that to say it's very important that you not only have the right expertise in terms of actuaries and actuarial precision, but you also have an interconnected operating system that allows you to move from design to analysis to reconciliation in a much more seamless way, right? So that's kind of the future vision that we're trying to paint here. And as we move forward, let's go to the next slide and just talk about each of these buckets in a little bit more detail, starting with on the left here, design. Right. So again, this is the phase that I think really kind of sets up provider organizations for potential success or failure. You can do everything in your power to manage population health and manage the risk of the population, but to really be intelligent about the process, I think provider organizations really need to think about this in the same way that payer organizations think about taking on risk, which is what are the risk terms that organizations are taking on, and then what is the population that the population's risks that they're taking risk on. And so when we think about an innovator, what are the levers that we're really trying to influence in contract design and modeling? It's really three things. So that first is understanding comprehensively what are the risk terms that you're entering into. And so in the screenshot that you can see, this is a tool that we've developed in terms of modeling various risk terms that you would see in contracts with different target outcomes, with different qualifications, with different quality gates and so forth. And so really being able to replicate and mathematically calculate the risk terms that you're getting in these contracts is probably, one of the most important pieces here. Again, that's deciding and determining what terms of risk you're taking on. The second then is deciding what patients ultimately that you're managing and you're taking risk on. And so in a payer world, that's a little bit more straightforward. In the provider world and the VBC world, that determination actually is very closely aligned with the providers, since all of the patients really become attributed to providers, and that's usually the heart of these contracts. So understanding the second lever of which providers and which uh, provider groups even may be helpful or harmful in terms of setting up the potential for success in that value-based care contract. And that second lever comes with not two sort of considerations. One of which is just the organization that you're managing directly, and whether the participants in this value-based care contract should be all of that, some portion of that, or the majority of that. The other is then getting insight into data that you potentially don't have within your organization. So these are, potential providers that are out there that you could achieve some sort of partnership or affiliation with, so that you can create a more robust network in this value-based care arrangement. And so, that's the other area that we see, organizations toggling a lot, which is, which providers among my own organization should be part of this risk contract, as well as what other providers should I think about bringing in. And that second piece requires a more comprehensive data asset with which to understand the potential of those prospects that are out there. The third piece that I think organizations don't always think about quite as much, and we believe needs to be an essential lever in this phase, is really then what is the potential of the population that I'm working with, right? So again, just to recap, we have two sort of fairly straightforward levers. One, which is the risk terms that you're taking on, and then the population that you're taking risk on. The third one is, we think, in terms of getting ahead of success and getting a jump start to operations, is really being able to assess what are the opportunities for improvement in that population that I'm taking risk on, so that you can, from day one, enable the operations around whether it's to get folks in for quality improvement, for clinical documentation, for some sort of complex care management. If you understand before entering into the contract what is the potential and what are the potential hotspots of that population, you have a much greater chance of actually enabling that before you actually start managing the contract, and potentially waiting a few months before you get enough information to be able to enable those operations. So those are three levers that we think about are as critical in terms of contract design and modeling. And obviously there's a technology play here too, which is to understand and be able to compute and model out those explicit risk terms, the ability to run what if scenarios in terms of which providers are included or not included or added or affiliated. And then the third one, which is more traditionally analytical, is assessing the population risk itself ahead of the contract, so essentially what is the potential for improvement within that population. Is there anything else that, Puneet, you think about when, obviously Humvee has done a number of these in terms of helping providers understand their potential risks in terms of entering into a value-based care contract?
Yeah, so as I mentioned, design part comes in a lot of years of experience. Every contract is different. I can speak on primary care-based contracts. As Jim already mentioned, quality metrics is a gatekeeper. I've seen sliding scales. Every contract has their own nuances. some contracts have outliers. They are, let's talk about Medicare Advantage. They have all these supplemental benefits comes in that you're designing during the bid season, and that is something will be done for the next year, 2026. Um, and our providers really know what was decided in the bid season, what supplemental benefits were added, how will those design impact or the contractual relationship will change, let's say in 2026. It becomes critical how every year that whole process is done, and understanding all the nuances around those changes. Uh, in this tool, basically, we try to capture as much as we can, but there always be a nuance where that's where actuaries will come in, will calculate the actual value and try to implement in the tool itself. So the next cycle, when all those when we analyzing or reconciling, we can capture all the nuances that came along with the design part.
Yeah, that
Um,
that makes a lot of sense, Pani. And again, that goes back to the fragmentation of data. If there are, benefit changes and more enrichment in certain supplemental areas, that is information that the payers have that the providers don't always necessarily have privy to, but are very important in terms of understanding the potential success for their value-based contract. And so, you know, in some instances, we can capture the effects fully through technology and uh, things like AI. In other cases, we need the actuarial expertise to really lobby and champion for the inclusion of that information as you're in the negotiation phase, right?
Yeah, I
Okay.
can give a pretty good example on Part D. The whole Part D redesign happened in 24, 25. And if you were in any Part D contract where you didn't have much control over rebates or cost share changes, a lot of providers were out of luck from that point of view. They have to rely on payers. And those are things that you have to be upfront when you're designing um, and what tools you have to make the decisions.
Yeah, absolutely. Great example. All right, let's move forward to the next phase then, since I think we've talked quite a bit about that design phase. I think in this phase, it's a little bit in the analyze phase, it's a little bit more straightforward. We go back one slide. Yep. So this is, I think, where organizations are typically familiar with operating a value-based contract and thinking about the performance. But the specific lens that we're taking here is what does that all mean in terms of contract performance? Because the raw data that you receive and manage in attempting to manage these populations requires potentially some massaging to really understand how that ultimately relates to financial performance. And so really being able to understand and tie in the contract terms with the data that you're receiving to manage this population becomes a critical uh, next step, if you will, or next level before you can truly understand where you should be focusing your operations, right? So, you can manage a population with the best of them, but if you're not honed in on exactly how that will impact or affect the financial outcomes, sometimes those efforts are going to be less useful than if you were to center around the right opportunities. So, um, anything that you might want to add here, Puneet, around when it comes to actually after you sign a contract and you're trying to look at the financial performance of the population that you're managing.
I think this kind of goes hand in hand with reconciliation, making sure we understand all the contract nuances that we
Mm-hmm.
signed up. And first quarter and first few months are critical as we are setting up how we analyze all the data that we're getting, how these contracts are designed, what is the profitability coming in, and my world kind of stays more in the reconcile world of, hey, we signed the contract and how we are performing against that contract. Um, and so it kind of goes back and forth between analyze and reconcile. So yeah.
Yeah, it makes sense. And I think, the other thing that we want to call out here is we recognize that provider organizations are managing, dozens, if not hundreds of value-based contracts at this time. And so having a view into how each contract is performing becomes ultimately very critical, and requires some sort of technology in order to manage that process scalably, since doing it that at a, with oodles of actuaries might be a little bit challenging. So, but to your point, Puneet, I think a lot of contract performance management and analysis is identifying opportunities, but also understanding how you're going to trend towards the end of the year. And so let's move to that last phase, which is reconciliation here. And so if we go one slide forward to reconciliation. Yeah, and so I think this is the phase at which, if you're doing all of these well, and if you're getting the data that you need from from the design phase to the analysis phase, ultimately the reconciliation becomes easier, and you are essentially, truing up what effectively is a financial statement, as you can see in this screenshot. You're truing up that, as the year progresses or as the contract progresses, that you're getting this sort of continuous reconciliation of something that would actually be audit ready, that you can take to the payer and say, look, this is the data that I've been working with. These are the contract terms that you've given me. This is the performance that I've done. And these are the results that I actually expect. So it becomes a powerful tool in terms of, again, not all in negotiation happens up front. Some of that happens in the reconciliation stage too, and ultimately trying to get as correct and precise a settlement figure as all parties believe it should be. So, yeah, Puneet, you already talked a little bit about this reconciliation stage, but any insights or anecdotes that you might want to share in terms of how this comes out?
One thing is the beauty about this tool that Jim is showing, we can design this thing with multiple contracts. Hospital systems have hundreds of contracts. Provider groups, if they're specialty PCP, generally they have few with pairs as well as this. So we can, most of them, 80% actual principles apply the same, right? Trends, IBNR, seasonality, normalization of risk scores. But every contract will have their own nuances. When it especially comes to specialty, either cardiology, nephrology, understanding those nuances, like if you're in nephrology, you need to understand how CK3, CKD3, AB, and then how it progresses to 5, what is optimal stars. So those are nuances that our actual team will spend a lot more in every contract and trying to bring that summary from the reconciliation so you can compare one contract against others, how they're performing. And the way we work is like basically along with this reconciliation, what really is impacting? Is it the readmission rate? Is it inpatient? Is it members are seeing what's happening with Part B drugs because they can be pretty expensive. So that is where we start looking at like GLP-1. Everybody knows a couple of years ago when they came in, how expensive those were. So those are things that we will look into reconciliation when we are off and spend a lot more time understanding why that is happening, why we are off against budget. So the last quarter of every year, we'll spend time setting up a budget with your team. And Q1, if there's any change in membership, demographic, how we need to reallocate or readjust our budget, and then go against that budget line. And it will help us improve not only the year one, but year two, how your business performs, how your care managers are taking action. And that's where the reconciliation, not just the numbers, we take a deep one step down to understand what's really making the impact.
Yeah, that makes a lot of sense to me, and I want to call out the example you shared, which is, back to the point that negotiation doesn't necessarily stop or conclude at the design phase. In the reconciliation phase, ultimately what you're trying to assess is, did my organization perform the risk management that it should have, and should we be rightly rewarded for that? Now, the thing that isn't always captured in either design or analysis, and ultimately pops up in reconciliation, is surprises that happen on the population, like your example around GLP-1s or even COVID. In terms of how these contracts are structured, almost always it's looking at previous data, past data, and trying to predict or forecast something into the future. When there are surprises that jump out that either affect your performance or the payer's performance and so forth, or their projections, that is actually another opportunity for negotiation and potentially for rebaselining or rebenchmarking, even at the reconciliation phase. So, just another reason why it's important to fully understand, what actually transpired in that value-based care contract. So, all right, so I think we've spent enough time on the reconciliation phase, and that kind of takes us to the end of the life cycle. So we'll kind of just wrap up in terms of summarizing kind of all the things that we talked about here. So if we go to the next slide, please. Yeah, so when we think about what should be 2026 ready for provider organizations, it's really all of these three phases on one stack, one technology stack that can enable your contract design, whether that's scenario or network modeling, whether that's understanding contracts and storing them, whether that's using, a AI copilot to understand them, which we'll talk about in a future session. That needs to be on the same platform as your performance analytics and workflows that really kind of identify the opportunities for you, allow you to understand what is insightful in this population as it relates to the contract and what you can take action on. And then finally, in the reconciliation phase of truly understanding, from an actuarial perspective, did things happen the way we expected them to, or did something unexpected happen in the data and we need to make some sort of adjustment for that? So the governance and auditing of that whole process, really should live in the same platform ecosystem, the technology stack as the prior two. And so, the way we think about that is this system then becomes predictive. It's connected, it's AI powered, it's real time, it's compliant and secure, and ultimately it sets you up for success in value-based care. So with that, I think we'll open up to questions from the audience if there are any on anything that we shared or anything around value-based care analytics or contracting analytics. So just looking at some of the questions that are in the Q&A, I think one relates to, one of the biggest problems that we've identified, even in our poll at the very beginning of this session, was the fragmentation of data. And so I think from our perspective, that's, one of Innovator's core strengths historically is having one central data platform that can coalesce and bring together all data, whether it's claims data, whether it's clinical, and as we move into this next stage of analytics, whether it's contract related and even potentially benefit related. And so the only way that happens is by having a vocal champion to understand what data is pertinent to being successful in this case. And that comes with experience and expertise in managing value-based care contracts and value-based care initiatives. So oftentimes, I think provider organizations or organizations generally might just assume that the data that they've got is comprehensive enough to be successful to work with. But I think having a broader purview of exactly all the things that are potentially related, that allows you to go ask for information that you wouldn't have. And also when you find data anomalies in the data itself, that's another opportunity where the expertise and experience can be useful to help negotiate, identify, and then negotiate for better quality data. Because in our experience, we've seen a number of cases where, you organizations receive data from payers and assume that that's, gospel or perfect. But in reality, there are a number of potential challenges or nuances that require further refinement. And that's important, that's an important initiative to pursue. I think there was another question around supplemental benefits that we covered earlier. Um,
Yeah, this is what I was talking about. Depending on what type of contract it is, I was giving an example on Medicare Advantage, where during the bid season, a lot of benefits are changed. And how do you contemplate what's going to happen in the next year contract? How providers should react to it? Simple example is vision benefits or dental or out of total cost OTC drugs. Those are like standard in Medicare Advantage world that happens. Um, the only thing is providers need to understand what goes in the bids, how the benchmarks are changing, what is the rationale for payers to make those changes. And that is where, after the bids are done, I think coaching or training needs to be done with the provider groups. What changes were made and why those changes were made in the bids, and how will that impact, if you are in an MLR-based contract, how will that impact your target goals?
all right, great. Well, I see no further questions in the Q&A. Then I think we can wrap up early here, and I thank everybody for their time and attendance today.
All right. Thank you. Thanks, Jim.
Thanks, Mandeep. Bye, everyone.